Hey, wait, it is not a recall session of INI CET. It is much more than that. We'll discuss in this INI CET pediatric recall. We will not just see recalls, but we will discuss topics around these recalls. Hey, welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj. I'm pediatrician by profession and teacher by passion. So we will deep dive into this and crack some topics for your exam, and it will be beneficial for upcoming exam also. So without further delay, let's start our discussion of questions along with amazing discussion. So be with me. We're starting. Okay. So the disclaimer, as all we know, going forward to next question. Okay, so the question is, just be with me. We will see highlighted or key points in this question. In this question, what they're asking, in 9 month old child, okay, first age is given is 9 month, brought to OPD with concern of delayed development. Okay, child can roll over, babbles dada mama, has stranger anxiety but cannot sit without support. Okay, first you have to just highlight keywords in your mind or your in your exam. It is 9 month age is given, can roll over, bubbles dada mama, stranger anxiety but cannot sit without support. If I will tell answer straightforward, so it will be similar to other recalls, but what we will do, we will build your concept now. Okay, at 10 month of age, 9 to 10 month, what happens in normal child, normal infant? Okay, at 10 month of age, child sits up alone. Okay, it sits up alone indefinitely without support with back straight. Okay, so 9 month child can sit without support, standing, pull to standing position, cruises and walks holding on furniture. We'll discuss them also. Baby creeps or crawl at around 9 to 10 months, and generally it used uh, pokes at thing with forefinger. Okay, picks up palette with assisted pincer movements, uncover hidden toy, attempt to retrieve dropped object, that is important, release object grasped from by other person, and language mama dada. Social response to sound of name, peeks a play, peek a boo, or pat a cake and waves bye bye. Why I'm discussing all these? Because they have asked 9 month milestone. In another exam or another scenario, they can ask any keywords from this. Okay, so you have to be well versed with these bye bye, peekaboo, mama dada, poke at finger, assisted pincer movements, back straight, cruise, creep, scroll. Okay, so you have to be very well versed with these terminologies. Okay, so in this diagram you're able to see a child is pulled to stand at 9 months. So this is clear, pull to stand. Stands holding furniture at 9 months. So he's holding furniture. Okay, pokes at small objects at 9 to 10 months. We all pokes at some time, but we start actually what is poking, we start at 9 to 10 months. Okay, then baby looks for dropped cube or dropped object at 9 months of age. He is looking down. Okay, immature pincer grasp is present as 10 month of age. Okay, so these are milestones at 10 month of age, but this actually, after this, our question solution is not yet arrived. So what we will do, okay, so just wait, we are discussing this question in detail. I'm building your concept, I'm just not telling answer. I can tell answer only, but it will not solve the purpose of our discussion today. Okay, so these are developmental delay. Upper range is given. Okay, at 3 month of age, what is the upper range of developmental delay? Supports weight on forearm. At 6 month of age, sit momentarily. 9 month pull to stand. 12 month walks with one hand held. 18 month walk upstairs with assistant, and 24 month means 2 year baby runs. along with fine motor, social and language skill. This is actually your DIY, do it yourself table. You have to remember and memorize all these developmental delay upper range. Trust me, it is required. Okay, coming back to our question. Okay, so 9-month old child which can roll over, okay, and bubble Dada Mama. So this is 9 month, as we discussed just now. Stranger anxiety, it comes around 7 month. Okay. Child can roll over 6 to 7 month. Okay. But child cannot sit without support. This is slightly off track. We'll see 9-month child should sit without support. Okay. So what we'll see, ordinary immediate MRI? No, immediate MRI is not required because child is achieving milestones. Okay, one milestone slightly delay, but MRI is not required. Refer to neurologist, similar thing, neurologist opinion is not required. Pediatrician observation is sufficient. Okay, advise physiotherapy. Why physiotherapy should be advised? It is out of question. So answer will be this: reassure the parents that child development is normal. Okay, so this is actually answer. To reach this answer, you have to actually well versed with milestones and the upper range of milestones. We'll discuss milestones as a whole in a separate topic some another day. Okay, going forward to next question. The question says most common inherited bleeding disorder. This is directly one liner picked from Nelson or Ghai textbook of pediatrics. Okay, it says, Nelson says, von Willebrand disease is the most common inherited bleeding disorder. That is important. The prevalence is 1 ratio 100 to 1 ratio 10,000. Okay, and generally it presents with mucosal bleeding. So all you need to know, this is most common inheritable bleeding disorders is von Willebrand disease. But will not stop here. We'll discuss this amazing table. Okay, this is extra edge. Okay, if you want to remember this, especially for INI CET. Okay, the most common type of von Willebrand disease is type 1, that is caution. Okay, so another are 1C, 2A, 2B, 2M, 2N, type 3. Okay, just focus where we I am discussing. Most severe form is type 3. Why it is most severe? In this condition, von Willebrand factor is completely absent. That is very important. Okay, another thing I want to actually remember to you is type 2B is leading to thrombocytopenia. Thrombocytopenia because it is leading to platelet clearance. Which von Willebrand disease is mimics hemophilia A, that is type 2N. Okay, so recap it. The most common von Willebrand disease is type 1. Most severe is type 3. Okay, mimics hemophilia A is 2N and associated with thrombocytopenia is 2B. This is extra as you want to remember. You can remember this. Okay. Going forward to a child, 2-month-old child with suspected with severe combined immunodeficiency. It is immunodeficiency disorder of severe grade in neonates or infants, comes for routine immunization. Which following vaccine is contraindicated in this child? Okay, as we know, journal narrative is that child is immunocompromised. So don't give him live vaccine. This is journal basic narrative. Let's see what Nelson says. In this condition, mumps, MMR, mumps, measles, rubella, varicella, rota, oral polio, nasal influenza, yellow fever, BCG vaccination are contraindicated. Okay, basically live vaccine are contraindicated. So here, first I'll discuss answer and after that I'll discuss the treasure behind it or what it looks like actual case scenario. Okay, first see, DPT is inactive, hepatitis B is inactive, IPV is inactive. So obviously MMR is contraindicated. Okay, so this is one question which is asking vaccination in immunocompromised children. But we'll not stop here. We'll go to this amazing looking table. Okay, don't get overwhelmed by this. I'll simplify this table for you. Okay, so, if B lymphocyte defect is there, okay, a child comes to you with B lymphocyte defect. B lymphocyte defects, what are the B lymphocyte defects? X-linked A gamma globulinemia or selective common variable immune deficiency, selective Ig deficiency, and IgG class deficiency. Okay, if X-linked A gamma globulinemia is there, all live vaccines are big no, contraindicated. Okay, but common variable immunodeficiency also mimics same. So, two conditions, which two conditions? X-linked A gamma globulinemia and common variable immunodeficiency, all live vaccines are contraindicated. But just remember, in selective Ig deficiency, only OPV is contraindicated, and IgG subclass deficiency, you can give any vaccine. So imagine a next question is on selective Ig deficiency, IgG class deficiency. I know it is level up, but it can be made. And if you revise this table once, it will be sorted. T lymphocyte defects. Okay, now our question is severe combined immunodeficiency. So it says all live bacterial and viral vaccines are contraindicated. But just remember one thing, live vaccines are contraindicated, but all inactive vaccines are ineffective. If we are giving IPV and other inactive vaccines, they are ineffective in SCID. Just remember, very important. Okay, other disease which mimics similar presentation like all live and bacterial vaccines are actually contraindicated and inactives are not working. This is complete Dijon syndrome. Okay, so this is in combination complete Dijon syndrome and SCID. Okay, so they can make question on complete Dijon syndrome next time. Okay, you have to remember. Another thing like partial Degog syndrome, Viscott-Eldridge syndrome, hyper-IgM syndrome, and ataxia telangiectasia. In these conditions, all live and bacterial vaccines are contraindicated, similar to similar to SCID and complete digital defect. But what is important? All inactive vaccines are safe and may be effective, and MMR can be given if more than 500 CD3 T and more than 200 CD8 plus T lymphocytes are there. Okay, so just revise this table once again, pause this video. This is very simple. It is just in table format, and if any question is asked out of this, it will always be upper edge, upper hand. It will actually rank decider in within less than 100 ranks. It is a rank decider. Okay, it will be rank decider if this question comes. Okay, going forward, just focus on what I'm telling. Going forward, complement deficiency. So in these conditions like C1 to C9 protein factor B deficiency, no vaccines are contraindicated. You can give all vaccines. Chronic granulomatous disease, all live bacterial vaccines are contraindicated, just remember, but you can give all inactive and all live virus vaccines can be given. Very important. In this condition, only live bacterial vaccines are contraindicated. Remember, in SCID, and all live bacterial and viral vaccines were contraindicated. Okay, phagocytic defects. In these, all live viral and bacterial vaccines are contraindicated. Okay, so this was overwhelming question. Okay, so just pardon me because this is extra edge for you. Going forward to simple question. Okay, so this question is, which of the following findings is not typically associated with Turner syndrome? Okay, what Turner syndrome is? XO, all we know. Okay, so finding before answering this question, you have to go to finding of Turner syndrome. Okay, so this is beautiful looking table. Just imagine a Turner syndrome patient. Okay, so short stature, yes. Congenital lymphedema will be there. Horseshoe kidneys will be there in Turner syndrome. Yes. Question, important question is there. Increased carrying angle of elbow, it is also PYQ. Mad lung deformity, it is also PYQ. What is mad lung deformity? It is seen in Turner syndrome. It is chondrodysplasia of distal radial epiphysis. Just remember, okay. Widespread nipples and shield chest, okay. Low posterior hairline. I'm just highlighting important one. Coaction of aorta, bicuspid aortic wall, gonadal dysgenesis leading to infertility and primary amenorrhea. Very important. Gonadoblastoma, increased risk of Y chromosome material is present. We know Y chromosome material is prone for gonadoblastoma. Learning difficulty, this was PYQ. Learning difficulty seen in 70% patients of Turner syndrome. Developmental delay, on the other hand, seen only in 10%. Very important. Okay. So hypothyroidism is seen in 15 to 30%. Cataract and which blindness? Red green color blindness. It is also PYQ. Celiac disease incidence are increased. Okay, so this is diagram. You can remember this diagram along with this, but this table is sufficient. Just revise me with me once again. It is very simple to revise it. Short stature, congenital lymphedema, horseshoe kidneys, increased carrying angle, that is cubitus valgus, Madelung deformity, widespread nipples, low posterior hairline, coaction of aorta, gonadal dysgenesis, infertility in primary amenorrhea, gonadoblastoma that leading to increased risk of Y chromosome material is present, learning difficulties, developmental delay, hypothyroidism, cataract, red-green blindness, and celiac disease. Okay, so this is beautiful diagram. Actually, this diagram can come in your exam. In this, you are able to see this is low hairline. Okay, you are able to see shield chest, widely spaced nipples. Okay, this is also low hairline. In this diagram, you're able to see this webbed neck. This is webbed neck. Again, this is shield chest and nipple separation. So this actually like similar exam, similar image based question can be asked. Okay, this is you're able to find edema of hand, edema of feet. This is lymphedema, lymphedema seen in Turner syndrome. So these images you have to remember. Coming back to our original question, forgot. So they are asking Turner syndrome findings. Webbed neck, yes, it is finding. We just saw. Short fourth metacarpal, yes, it is finding. Just we have discussed. Widely spaced nipple, yes. Prominent occiput, no, no, dear, it is not the finding. So it will be the answer. In which condition it is found? It is found in Edward syndrome. Edward syndrome. So this is very much important. Okay, so we have discussed Edward syndrome. Next question can be on Edward syndrome and Patau syndrome, that is trisomy 18 and trisomy 13 respectively. Okay, as we discussed earlier also, we are not just discussing questions, we are just discussing topics around them. We are covering many topics around them actually. Okay, so trisomy 18 Edward syndrome, just you have to remember some keywords. This is game of keywords. Hypertonia, okay, micrognathia, short sternum, flexion deformity of fingers, and rocker bottom feet. If these are given in your exam, it will point towards trisomy 18 Edwards syndrome. But if microcephaly is given, cleft lip without or cleft palate, holoprosencephaly, iris coloboma, retinal dysplasia, polydactyly, flexion deformity, and more incidence of congenital heart disease, these are in favor of trisomy 13 Patau syndrome. Basically, you have to remember keywords that's it in these syndrome. Okay. So this is actually trisomy 18. In this condition, facial dysmorphism, you are able to see an overlapping of fingers. This particular image was PYQ, actually PYQ. Okay, this is image of trisomy 13. You are able to see extra finger, that is post axial polydactyly, extra finger. Okay, so these were extra as other topics around this question. Okay, going forward to another question. Okay, this is my favorite hematology question. I'll discuss it in detail. So be with me. Question says 5-year-old boy, okay, presents with pateke, agree. Platelet count is 10,000. Okay. Bone marrow aspirate shows normal cellularity with megakaryocytic hyperplasia. What is the most appropriate initial therapy? First, before going to therapy, actually you have to diagnose this patient. Okay. Generally, what this patient is 5-year-old boy with patekes and platelet counts are low. So it looks like his platelet counts are low. That's why some bleeding manifestations are there, but they have given bone marrow finding also. So before going to treat, just see what this disease is. Okay, this disease is ITP, idiopathic thrombocytic purpura. Okay, so keyword you have to remember. This is most repeated question in actually INI CET exam. Just see, just forget everything. You are sitting in OPD and a patient is coming. What are the demographic? What are the characteristic of this patient? Clinical character of this patient is patient. Your patient is chotu child, 1 to 4 year old. He's previously healthy. Okay, these are keywords. Just remember, sudden onset of petechiae in purpura. And child was fine with previous day. Parents are saying, sir, our child was very fine in last night. Suddenly child woke up and we saw any many petechiae over his like whole body. Okay, you did investigation CBC, we found platelets are low as much as less than 10,000. Okay, and you found, sir, our child got upper respiratory tract infection, cough and cold, like 20 days back. So, viral infection 1 to 4 weeks before onset of thrombocytopenia. You did physical examination, which is absolutely normal, and you are not finding any splenomegaly, lymphadenopathy, and bone pain. So this is classical case scenario in pediatrics, basically. So these all amalgam of these clinical scenario, examination, investigation findings suggestive of ITP. Okay, first we have to be well versed. So in our case scenario, it is Peteke's 5-year-old boy, platelet count 10,000. Okay, so this is looking like ITP. Bone marrow, what happened in bone marrow in ITP? Okay, bone marrow examination is not routinely indicated. This is very important. We don't do bone marrow examination routinely. If we are happen to do bone marrow examination, we will found immature megakaryocytic. You are able to find, see this? These are immature megakaryocytes in bone marrow. If you are do peripheral blood examination, you will found large platelets. Okay, basically platelets are overproducing. So coming back to our question says normal cellularity with megakaryocytic hyperplasia means platelet are producing more. So our question is suggestive of ITP in examination bone marrow finding. Now treatment. Okay, Just come with me. So this is a table, a flow chart, which is actually important to decide therapy. Okay, not just overwhelm you guys. Just be with me. It is very simple. Okay, remember that child that came in your OPD? So that child came in your OPD. He was very fine. No symptom was there. Okay, okay. And if symptoms were there, very mild, like bruises were there, fatigues were there, or minor epistaxis. Just that, nothing else. What you will treat this child? No, you will not treat this child. You will counsel his parents. "Okay, this is ITP. You can go home, and if any other symptoms arises, you can come back." Okay, just send the patient home. This is That's it. Okay, but your symptoms are moderate or severe. What are the moderate symptoms? More severe skin and mucosal bleeding. The key word here is mucosal bleeding. Means gums are bleeding, means mucosa, oral mucosa are bleeding. Any mucosal bleeding is there, and epistaxis is more. That means moderate bleeding and severe symptoms like severe bleeding, menorrhagia, epistaxis requires hospitalization. So any symptomatic child having more severe bleeding, especially mucosal bleeding, requires treatment in ITP. So what we should give? IVIG is first line, second line is corticosteroid. Simple. Okay, so IVIG dose. Okay, 0.8 to 1 gram per kg per day. This is extra edge. If you don't want to remember, this is it. IVIG and corticosteroids are used. Okay, so it is for 1 to 2 days. Mechanism, if you want to remember, it is down regulation of FC mediated phagocytosis of antibody coated platelets, not required at your level. Okay, corticosteroid dose is 1 to 4 milligram per kg per day. That's it. Are any other treatment? Can we transfuse platelets? No. Platelet transfusions are not indicated because they generally will break down. But in ICH, yes, you can intracranial hemorrhage, you can transfuse platelets. Splenectomy, what are the indication of splenectomy in ITP? I'm going slight far from the topic, but I'm just covering the whole topic for future proof, okay, for future examinations. So indication of splenectomy is your child should be more than 4 years of age, and ITP should present for more than 1 year. That is chronic ITP in child more than 4 years of age, do splenectomy. Okay, and if life-threatening hemorrhages are there, you can do this. Okay, so this was treatment protocol of ITP. We just forgot our question. So coming back to our question, we have diagnosed this condition as ITP. Now they are asking treatment. So our patient is having only petechies. Okay, sorry. Our patient is having only petechies and his platelet count is 10,000. No other symptom are there. Okay, just a gentle reminder to all. These are collected questions. Okay, questions might be different, language might be different, and actual question may vary from examination, but the crux, but the concept will same. That's why I'm giving you this slide. Okay, any question if it is coming examination, maybe it is incorrect recall, but this treatment protocol will remain same. Okay, so from this recalled question, because this is having only petechiae, okay, these aspirin, no, aspirin, bro, it is out of the question in ITP, no. Bone marrow transplantation, no, bro. Methotrexate, no. IVIG, if this question is there, IVIG can be given, no. Answer should be reassurance, reassurance to parents. This should be the answer. But if it is not given, then IVIG should be the answer. Okay, so my first answer is reassurance to patient. My second option will be IVIG if more symptoms are there. Okay, so this is how we will approach this question. We will not mug up this question. If you will mug up this question, this will actually, you're not future proof then. Okay, so going forward to this is also, I think, a controversial collected question. Just see, in newborn born at 36 week of gestation means near term. Okay, 37 week is full term, it is near term. Respiratory distress shortly after birth. X-ray shows prominent vascular markings and fluid in intralobular fissure with hyperinflated lung. Okay, I don't know what is exact recall question, but just remember one thing. Okay, at your level, I'm not discussing answer straight away. At your level, three neonatal X-rays are most likely to be asked. First is respiratory distress, second is transient tachypnea of newborn, and third is meconium aspiration syndrome. Just be with me. After that, you will not get confused in anything. Okay. So, respiratory distress syndrome, first X-ray, this is first X-ray. Okay, what happen in preterm newborn, surfactant is generally not formed. Okay, so RDS will be seen in preterm neonates. Okay, what this is the clinical profile. What will be seen in this X-ray? You are able to see diffuse ground glass opacities, like ground glass opacities with finally granular opacities, ground glass, and you finding some granules are there. Okay, and this is bilateral and symmetrical distribution. Along with, you are able to see hypoaerated lung. Okay, this is hypoaerated lung means your lungs are not fully expanded. So you found a preterm neonate having respiratory difficulty. Your lung field are small and bilateral granular opacities are seen. Along with, you find ground glass appearance like this. Your diagnosis will be respiratory distress syndrome. On the other hand, your patient or your neonate is near term or term, it is full term, generally born out of LSCS, cesarean section, and develop respiratory distress just after birth. Okay, but his or her respiratory distress generally comes down after 24 to 48 hours. Baby is feeding, baby is well. So just see this and just remember this clinical scenario once again. Your baby having respiratory distress at term age, and after 24 to 48 hours he's completely fine. Clinical scenario suggestive of transient tachypnea of newborn, as name suggests. Okay, X-ray. What X-ray will be seen? So these findings are very important actually. Fluids in minor fissure. So this is, if you are able to see this, this is fluid in minor fissure, mildly hyper expanded lung. RDS will see a low expanded lung, but in this expansion will be high. Minimal pleural effusion you might find or not. Streaky infiltrate. In RDS we found just granular opacities. In this streaky infiltrate, mild cardiomegaly and sunburst appearance. These are the keywords. Along with, just remember this X-ray and this clinical scenario. This will be case of transient tachypnea of newborn. Okay, another X-ray which can be asked from neonatology rescue part is meconium aspiration syndrome. Okay, classical scenario will be exact same. A term or near term neonate delivered with meconium aspiration. Meconium was spilled in utero during delivery. Baby is having respiratory distress. So what you will find in this, term infant will be there. Okay, so you are able to see in this condition many minor granular opacities with atelectasis means and local emphysema. Okay, so atelectasis, some lung field will be constricted, pneumothorax will be seen, okay, and fine irregular granular opacities will be seen. Okay, so again, just go through these images. Exam, if any image is being asked, clinical scenario, just see clinical scenario. In this our scenario, the baby is near term. and they have given actually explanation of X-ray finding. I don't know it was there in exam or not. Okay, but this description is actually compatible with TT, and again I am saying my answer will depend on the question provided. Okay, but concept will remain same. So my dear friend, this is important advice. Don't go for caution, recall caution. Just understand concepts. Concept will remain there, caution will forget. Okay. So going forward, a 3-year-old child suspected of having TOF, which is the most following finding present supports the diagnosis. This is a straightforward question. They are asking TOF TOF findings. Okay. So in TOF, pulmonary stenosis is there, thickened right ventricle, ventricular septal defect, and aorta override septal defects. This you have to remember, my dear friends. So nothing to explain. Yes, TOF will lead to cyanotic spells and all. We'll discuss them in another separate video. But as of now, left ventricular hypertrophy in TOF is not found. No, it is right. TGA, transfusion of great arteries. No, it is overriding. Interarterial septal defect? No, it is VST. Infundibulous pulmonary stenosis is our answer if question was framed like that. Okay, just understand the crux. We have to remember all four components of TOF. Okay, so which is not true about marasmus in children? Okay, this is, I think, okay, let's see. It results from overall calorie deficit, carbohydrate and fat deficiency. Mhm. Body weight is significantly below the expected age. Subcutaneous fat and muscle mass are markedly reduced, and protein loss is responsible for edema in this patient. We know somehow protein loss is associated with kwashiorkor. Okay, so edema is not a feature of marasmus. It occurs in kwashiorkor due to hypoalbuminemia from selective protein deficiency. Okay, so in this condition, answer should be this, because marasmus protein loss is not is responsible for edema in this patient. No, no, my dear friend. Okay, so this is protein energy malnutrition. This is actually vast topic. We can't explain this topic as a detail in this. We'll discuss this topic as a whole in some another video. Okay, if you are new to my channel, I have actually taken many videos on Nelson-based pediatric topics. It might be just go through all my playlist. I have shorts like image-based discussion also, table-based discussion also. Just revise, just go through channel. It's completely free. If you find anything useful, you can use that. It's all ticket free. Okay. So going forward to next question, which is following conditions of aneuploidy. This is actually simple, straightforward exam question. Trisomy 21, trisomy 13, Klinefelter syndrome, and Bloom syndrome. Bloom syndrome is not aneuploidy, my dear friend. This is actually chromosomal instability syndrome. Okay. So again, I'll not go to detail in this question because this is straightforward. Okay. Which of following explain the mechanism of breast milk jaundice? Okay, I'll not read the options now because this question is actually confusing, and again examiners know this breast milk, this breastfeeding jaundice is very confusing. It is confusing since undergraduate, since postgraduate, and super specialty also. So let's clear these two type of jaundice once and for all. So here, breast milk jaundice. Just apply your common sense. Breast milk jaundice means something is problematic with breast milk. Okay, milk itself is problematic. Okay, so it is seen in 2% of breastfed infant. It is also important. It occurs after 7 days and peak in second to third week. They can ask any question. Just stay your 100% attention here. Unconjugated bilirubin is increased. Okay, it goes up to 10 to 30 milligram per deciliter. Okay, and connectors is rare. So you have to see this. We have seen this, but what is the breast milk jaundice, my dear friend? Okay, So, breast milk, one thing is found, that is, what is that thing? That is thing, intestinal beta glucuronidase is increased in breast milk. What happened is after due to this deconjugation of bilirubin occur. Okay, that's why it leads to increase enterohepatic circulation. So anything which increase enterohepatic circulation leading to jaundice. Other thing, breast milk is having pregnadiol and free fatty acid. These two interfere with bilirubin conjugation. So basically what I want to say, intestinal beta glucuronidase, free fatty acid and pregnadiol, they leading to ultimately interfere with bilirubin conjugation, leads to breast milk jaundice. Okay. Another one which is confusing with this entity is breastfeeding jaundice. Just apply your common sense. Breastfeeding means something issue with feeding. Okay. Uh, American Academy of Pediatrics in 2022 says no, it is not actually breastfeeding jaundice. It should be renamed as suboptimal intake hyperbilirubinemia. So this is update exam. They can ask suboptimal intake hyperbilirubinemia. Okay, it occurred during first week of life. Dehydration is there in your neonate. Okay, hematocrit will increased, bowel movements decrease, that's why increase enterohepatic circulation. You understood the final mechanism is increase enterohepatic circulation, but the crux is it is due to suboptimal intake of breast milk leading to decreased bowel movement. What you have to do, increase breastfeeding and supplement breastfeeding. Okay, just pause this video, revise this slide once and for all, and you'll be sorted. Okay, coming back to our question, it is asking not breastfeeding jaundice, breast milk jaundice. Okay, so I'm just directly going towards our answer. Inhibition of conjugation. Inhibition of conjugation by substance like free fatty acid beta glucuronidase in breast milk. This is our straight answer. We have discussed detailed mechanism behind this. Hope you will not actually do wrong in your upcoming exams. We can easily rule out other questions. Hepatocellular injury by breast milk? No, my dear friend. Increase RBC breakdown? No. Reduce intestinal absorption of bilirubin? No. So this will be the our answer. Straightforward. C. Going forward, oh, this is also controversial. A 6 week old child, you have to see the keyword 6 week old child which has non-bilious, non-projectile vomiting starting at 3 week of age, no abdominal mass is palpable. What is the likely diagnosis? Just see, my dear friend. Okay, just actually this is question of great detail. You need clinical actually acumen to solve this, but be with me. Okay, first thing, bilious and non-bilious vomiting, anything above second part of duodenum will leads to non-bilious vomiting. Any obstruction below second part of duodenum will leads to biliary vomiting. That's clear. Okay, so just be with me. This is basic concept will apply if you don't know anything. Okay, so just find keywords in this. So what are the keywords? Keywords are non-bilious, non-projectile vomiting. Okay, so just see, intestinal obstruction is below this second part of duodenum, so it will produce bilious vomiting. This option is ruled out. First thing. Okay, then second thing, 6 week old infant, the age is given. 6 week old infant, cow milk protein allergy can occur, GERD can occur, and pyloric stenosis can occur. So this age is not differentiating our discussion of this. Starting from 3 week of age, when the neonate or infant was 3 week of age, it was started not before that. Again, very much important. So Cow milk protein allergy is actually age group is there. Cow milk generally, when cow milk is started, it allergy generally usually there as non-bilious vomiting, non-projectile vomiting. So this is unlikely. Still, we are not ruling out. We are left with two A and B options. Just see no abdominal mass is palpable. To just apply your basic sense, congenital hypertrophic pyloric stenosis, something is hypertrophic. So if something is hypertrophic, your mass will be palpable, my dear friend, palpable mass. It is ruled out. So GRD will remain. So your answer will be GRD. Okay. So this is actually clinical exclusion question which requires some clinical knowledge, but you can by step by keeping your mind cool, you can answer this. So we'll discuss this answer is GRD. Okay, please discuss then something with congenital hypertrophic pyloric stenosis. So just discuss abdominal finding or discuss it in detail. If you want a detailed discussion in this, go to my playlist of Nelson based video. In this, I have discussed this congenital hypertrophic pyloric stenosis in detail in 30 to 40 minutes video. Just one topic. If you want detail on this, okay. So we find this palpable pyloric mass 2 centimeter in length. Okay, located above and right to umbilicus. Ultrasound shows pyloric thickness more than 4 millimeter and pyloric diameter more than 10 to 14 millimeter. The diagnostic and string sign, shoulder signs are seen. So I have discussed them in detail. So you can go there. Our answer, our answer of this question is GRD. Okay, so breastfeeding technique. This question is about breastfeeding technique. Okay, just see, just remember this. Okay, signs of good attachment, 3 4 lines. The baby mouth should be wide open. Okay, baby mouth should be wide open. Okay, making baby hope it is baby. Okay, most of nipple and areola in the mouth, only upper areola is visible, not lower one. Okay, so this is mother breast. This is upper areola. It is very bad diagram actually. Upper areola is visible, may be visible, but lower areola should not be visible. Baby chin touches the breast. Baby lower lip is everted out. Okay, that how it will take the feed. Just revise with me again because this is very important. Breastfeeding, breast milk component, and other things around are important. Will important exam, especially in AIIMS exam. Baby mouth should be wide open. Most of nipple and areola in mouth. Only the upper areola is visible, not lower one. Baby chin touches the breast, and baby's lower lip is everted. Coming back to our question, baby lower lip should be inverted. No, my dear, it should be everted. So this seems incorrect. Baby cheek should appear full during effective suckling. Yes, because milk is coming. Greater portion of alveola should be covered below the nipple than above. Okay, yeah, this is right. The infant chin should make contact with breast during suckling. So clear cut answer from this. Okay, so this is crux of doing these question. If you know the concept, you will uh, you'll mark this answer right. So this exam, INICET exam, is conceptual exam. Your concept should be strong. Okay, you can't mug up all things. Okay, so going forward to a question. A child, 12-year-old child diagnosed with systemic lupus erythematosus with nephrotic range proteinuria, renal biopsy showing wire loop lesions with drug of choice. Okay, just wait. Don't get overwhelmed by this question. SLE is a disease we know, systemic lupus erythematosus. One of the common manifestation of renal involvement is called as lupus nephritis. Okay, that's clear. Lupus nephritis is the one of manifestation of SLE. So, lupus nephritis has many categories, classification, and they are asking wire loop lesions and sorry, they are asking wire loop lesions nephrotic range proteinuria, and they are asking drug of choice. Basically they are asking treatment of lupus nephritis. For this classification of lupus nephritis, just if you want to remember this, you can remember, but generally overview I'm telling, it is classified in six: minimal mesangial, mesangial proliferative, focal proliferative, diffuse proliferative, membranous lupus nephritis, and advanced sclerosing nephritis. Okay, just forget first two conditions. In third or fourth, this is actually active serology. Nephrotic syndrome is found 25% patient, hypertension is there, okay, reduced GFR is there, and wire loop lesions are seen in this, mostly in this condition. Okay, and membranous and advanced, these are actually often nephrotic with less active lupus serology, and advanced it is glomerulosclerosis. Basically first two are milder presentation. Third and fourth are proliferative lupus nephritis, focal and diffuse. All wire loop lesions like condition are seen along with nephrotic syndrome. Other two are severe condition. So what are the management of these two conditions? I'll not go into detail. The management will be cyclophosphamide with methylprednisolone. Okay. So basically, in this condition, if you want, if you'll ask me, sir, explain these cyclophosphamide and methylprednisolone in detail. So I have made SLE nephritis, lupus nephritis video. Just go through my section of this like Nelson-based chapters. You'll find them there. So till we have discussed, I think 9 to 10 questions. If you find another question, just put them in comment down below. And if you find this lecture interesting, do share, like, and subscribe. Okay. So I'm thinking of a fast track revision of NEET PG, pediatric based. Okay, so it will cover all PYQs. If you are guys up for it, and if you like my teaching method, I'll come up with similar kind of a wholesome fast track revision, rapid revision of pediatrics, for especially for NEET PG. If you're interested, comment down below. Okay, we'll meet in another